Where is this trending? It doesn't sound like it's trending in a great direction.
The fact that the governor's talking about shutting down the state, you know it's bad. That's the last thing he wants to do.
At what point does the positivity rate, do they go, okay, that's it, we're shutting it down? I mean, has that been defined, Eric? Have you seen where they've defined if it hits 25%, that's it, that's the threshold?
Yeah, not to where there's a trigger for, there's no one trigger that is like, if this, then we shut everything down. So you're looking not just at positivity rate, but you're also looking at things like hospital capacity, at what are maybe some of the contributing factors for the positivity rate. You're looking at special populations like hospitals or nursing homes, and seeing, because that's where we want to keep the disease out of, nursing homes especially, because that has such a high mortality rate. If the positivity numbers go up, and I don't mean spike, I just mean moderately up, but we see that it's mostly 20-somethings, then that's a concern, but it's not quite the same concern if we see it go up and it's mostly 70-somethings. Then it's a much scarier number because of the potential for loss of life. It's the younger you are, the more likely you are to survive COVID-19. And that's why there is no one number or no one metric where it's like, if we hit this metric, we're going to shut everything down. It really is up to our public health leaders or experts to kind of take all that information in and make a call based on their judgment and assessment of the situation.
Welcome to the Your Houston podcast. This is your host, Nicholas Hall.
And this is your co-host, Mario Castillo.
How are you doing today, Mario?
I'm doing wonderful today, ready to dive into the world of COVID-19 testing.
Testing. We have a wonderful guest today, Eric Bakota. How are you doing today, Eric?
Great. It's another COVID Saturday, so just here taking a small break from work and happy to chat with you guys.
Wonderful.
Well, we're happy to have you here, and to give everybody just a brief introduction, we have Eric Bakota, who works for the Harris County Department of Public Health. He serves on the Your Houston board and chairs the Health and Wellness Committee, which has put out a great policy paper around reduced parking at bars and nightclubs. He's born in St. Louis, but lives in Houston, Texas now. Got his graduate degree, his master's in biology from U of H. Very proud of that. And I actually met Eric at the City of Houston Health Department when we both worked in epidemiology at the time. And then he went to the county. I went to work for Your Houston, but here we are today.
Well, Eric, welcome to the show. And we're going to start off with a few questions. We like to do a little icebreaker around here. What's your morning routine?
What a great and interesting question in these times. And I just want to preface, I do work for the county, but I'm not here representing or speaking on their behalf. But I'm happy to share a little bit of insight into what I do and what I know about COVID-19. So my routine in this era of COVID-19 is every day around 8 o'clock, I'll wake up. We have our morning meetings with the people on the data team that I work with. Around 10, we get a big data dump that we then look at our numbers. We make sure everything looks right. We do some analyses and we share that information up to leadership. And eventually that's what makes its way to the dashboard on the website. And between 10 and I'd say about 6, it's a mix of data analysis and meetings. With an occasional break to just check up on all of the emails I'm falling behind on. And then from 6 to about 8 p.m., I'll get a break to eat. And then sometime after 8, most days, not every day, we'll do a couple of hours of either meetings or data analysis or catching up on emails. And my day ends usually around, I'd say about 10 p.m. But occasionally you kind of have to burn the midnight hour, burn the candle at the midnight hour and push through if there's a big deadline. And it's been like that for since March, really, just a 60, 70, 80, 90 hour work weeks. But it's been an interesting work experience and an interesting change to my routine. But I'm really honored by having the privilege of trying to do something proactive to help our community and help us get past COVID-19 together so that we can get back to some sense of normalcy.
Yeah, well, we appreciate everything you're doing. I see a drawing up there behind you. You got kiddos around?
Yeah. So in the midst of all this, my daughter, second daughter, Samira, was born. And so my
congratulations.
Yeah, we're going to do a little bit of round of applause on that one. Congratulations.
Yeah, harrowing experience. She came 7 weeks early, so she had to go to the NICU. My other daughter, Zoe, she made this welcome home picture. She wanted to make sure Samira knew the layout of the house, so she drew us a nice picture, and I'm here in my makeshift office in my kids' room.
Well, I love it. It looks wonderful. And so the last question I'll ask for you then is, are you a coffee person? How are you staying energized here? There we go.
Very much. Drinking a cup of coffee right now. Usually it's about 2 or 3 cups a day. Once in a blue moon, I'll try some tea out. But if it weren't for caffeine, I don't know how I'd be around.
Are you a black coffee person, or do you add creamer? You know, how do you like your coffee?
Black coffee. Yeah.
Hey,
that's the way to go.
Straight for the caffeine. I love it. That's the way I rock and roll. Well, thanks for being here today. We're going to talk about testing. And, this is an issue that I really don't know much about. So I'm very interested in learning more.
Well, Eric, you mentioned data and really spending a lot of time with that throughout your day, your routine. I think, it'd be important just to see where we stand as a county with the latest numbers. So this is as of Friday, as of 4 p.m., 42,000 confirmed cases, 28,034 active cases, 13,527 recovered cases, and 439 deaths. And this is all public information available at readyharris.org. There's some interesting data points and terms, and I think, if you could give us some insight into what these mean, it would just help folks better understand what these numbers mean, where you get them from. So when you look on the dashboard, there's City of Houston numbers, there's Harris County numbers, and then there's a combined total, the combined total of the numbers that I just read. And then you'll see case chart versus cases by day as a count. So what are the difference, what's the difference between those two metrics?
Yeah. Let me take a step back, and first I'll explain that why we have a Harris County number and a City of Houston number. And that has to do with, like you mentioned earlier, you and I, we met working at the Houston Health Department. So the City of Houston has a health department that serves the 2.4 million people within the city limits. And then Harris County has a health department, that's where I currently work, that serves the 2.5 or so million people who live in Harris County, but not in the City of Houston. And so it can create some administrative challenges to present the data in a way that makes sense to the community. But I think that the city and the county have done an amazing, impressive job of coming together and having this unified dashboard so that the public understands everything as clearly as possible. And with respect to the two different types of charts, we had there's a lot of different ways to present the data. And what the CDC has is they define a term called event date. And that's going to be where a case, let's just say, I got tested today, and I got my results today I'm a positive case on July 11th, but I got tested on July 9th, and I was symptomatic on July 1st. I likely got the disease sometime before July 1st, right? There's going to be a lag time between when the virus enters my system, when I have symptoms, when I go to get tested, and then when I get those test results back. And the two different graphs you see on the website reflect that you can show the data as an epi curve, and that's going to be where you use when I became symptomatic, because that's going to say you likely got the virus on or around July 1st when I got symptoms. And so that means even though I got tested on the 9th and I got the results back on the 11th, and the health department didn't know about me until the 11th, that really I'm a July 1st case. On the other hand, when you see on Twitter, on the news, like 800 new cases reported today, those 800 cases actually get shuffled back into the epi curve. And so, I think I'm confusing everybody on it.
A little bit of baby brain. It is confusing. I mean, that's what's so fascinating about this is I think that everybody's confused by it.
And this is why we appreciate you taking time to break this down for us, because, we are just, there's a lot of folks out there trying to understand this. This is really important information.
Yeah. And before we get epi curved out, I just want to start off with, I want to get tested. How do I get tested? I think I may have it. Where do I go?
So if you go to readyharris.org, you'll see an option to get tested, and it'll tell there'll be information on you can get tested at, I think, like CVS's and Walmart's, as well as tested by the county itself. So you can you fill out a little survey, a questionnaire, and then you'll get a unique identifier. It's just an alphanumeric number. And when you get that number, you take it, it'll say, please show up at this testing site at this address on this date at this time. You show up there, you share them the number that was given to you, and they will get you tested. You don't have to leave your car. It's all done in a very safe way. The nurses at this site will be wearing full PPE, protective equipment to make sure they're safe. And they'll walk you through the process. And what'll happen, and I've done this myself, when my daughter was born, I went through the process, I got tested, and it took me maybe 30 minutes to go into the testing site and to leave with my sample having been collected. And the nurses will put a long Q-tip rather in the back of your nose, and it is a unpleasant sensation, but it won't hurt you. It's not too terribly painful, just more unpleasant than anything. And that's where they collect the viral DNA and then send it off to the lab to get tested.
So just to clarify, if I live in the city of Houston, could I go to a Harris County facility for a test, or do I need to go to a city of Houston facility for a test?
It will, whether you're a county resident or a city resident, anybody who fills out the form, it will send you to the closest testing site that has capacity. So the system will say, okay, the nearest site maybe is full, so we'll send you the next closest one. Whether you're in the city or in the county, it won't matter.
And just out of curiosity, what's our capacity today?
Overall, I want to say it, if I remember correctly, mid 2000s tests per day.
So that's if you go through a public channel for testing, right? That's either city or county.
Right.
What about, I want to do like a telemedicine appointment and reach out to my physician. Maybe I was exposed to somebody. Maybe I got notice of something. How easy is that to get a test, and where would you go?
So you can call your provider, your PCP, and they will advise you on if testing is warranted, and you follow their advice and their directions as from your family doc. You can also go to several clinics in the area, like I mentioned, the CVS, the Walgreens, as well as urgent care centers. They will take samples from individuals and then send them off to the lab. Having said that, I don't know offhand their pricing structure. So I don't know if it would be something insurance would cover, if you'd have to pay out of pocket. Those would definitely be questions you'd want to ask before you go in to get a specimen collected. The ones operated by the city and county are free of charge.
So I guess another question I have is, all the tests, are they all created equal? Is the city, is county, and maybe we're not going to know the answer to this question, but are they all using the same test and same labs?
Simple answer, same test, yes. The complicated answer is no, it's not technically the same test. However, these tests do go through an approval process with the FDA. And so for the PCR tests, that's the one where they're going to put a Q-tip up your nose and they're going to send it off. That's the one we look at to determine if you have the disease right now. All those tests are highly accurate and reliable. And so I wouldn't worry too much that there are different labs that technically are looking for different segments of DNA. So a technical person might say, yeah, they're slightly different, but from a practical perspective, they're exactly the same.
So when I went to get tested at a City of Houston site, I had to do the actual collection.
So you've been
myself.
tested?
Yes, I have.
So both of you have actually gone through that. All right, so I'm going to have a lot of questions, but go ahead, Mari.
They put all the kit in a tub and they give it to you, and you actually put the Q-tip up your nose and collect the sample yourself, put it, seal it, and give it back. So it's the same experience that Eric had, except somebody administered the test to him. I administered the test to myself.
So what's the experience like? Does it hurt? Is it?
I think he described it very accurate. It's not necessarily painful, but it is unpleasant.
Okay. So you go get tested. How long before you get your results?
2 days I got my results.
Yeah, my results, I think, came back. It was probably about 3 or 4 days. And I do want to add that there is another type of DNA test or RNA test where you can get your results in 30 minutes. Those are the county facilities don't use those tests. But for instance, when my wife went into labor, that was the test they administered to her to know whether, they treated her assuming she had COVID-19 as a precautionary measure. And so they used that rapid test to be able to make sure she didn't have COVID-19, and that the staff and the nurses and the doctors who were treating her didn't have to worry about becoming potentially exposed individuals.
That's fascinating, because I didn't even know about the rapid tests.
I didn't either.
And I would assume that those are in a limited supply and used in most critical situations. So you get tested, you get your results in 2 to 4 or 5 days. It comes back positive. I'm assuming neither of you have tested positive. So we're not going to know the answer on that one, but it comes back negative. Can you then get another test if you have a negative test? Say you don't, for instance, say you get tested, say you're like, I really feel internally, even if it's psychosomatic or something else going on, but I really feel like I was exposed. I've been around somebody. It came back negative, but I still feel like I may have it. So could you go through the public channels to get tested again? Or is it you got tested, that's it, that was your shot, you're going to have to, give it a justifiable reason to get tested again?
From the county's perspective, no, there's no limit on how many times you could get tested. If you feel like you need to be tested or want to be tested, and you get the a slot at one of the sites, we'll test you multiple times, and that's important because if you do test negative and you've never had the disease, there's nothing to say you won't get it in the future. And so the critical issue is knowing who has it right now. And so if you get tested and a week later, or a month later, you feel like you have a cough or a fever, shortness of breath, then absolutely get tested so that the public health system is aware that you may have the disease and can do contact tracing to do it so that we can do our best to stop the spread of this disease. Without testing, we will have no ability to stop the spread.
So we're talking COVID-19 testing here with Eric Bakota, and all about the processes and the increase in testing. And you hear folks say, well, of course we're going to have more cases because we're doing more testing. But now you're also hearing about something called a positivity rate. So can you tell us what that is and how is that impacting, how y'all are interpreting the data and the results from these tests?
Yeah, and there is some truth to the more you test, the more positives you'll find. But that positivity rate is going to provide a lot of context. So if you see testing goes up and the positivity rate is also going up, then that's a clear indicator that the disease is in the community at a higher level than it was earlier. Because what the positivity rate is telling you, what percentage of tests on a given day or a given week come back positive. So it doesn't matter if you do 100 tests or 1,000 tests. If the positivity rate, the percentage of tests that are positive goes up, then there's a stronger evidence to suggest that the virus is spreading in the community more thoroughly.
So what positivity rate are we seeing currently? Do you know?
Last I checked, I want to say it's in the 20%, 25%.
Wow. That's gone up then, right?
I mean, that seems high, but what's your thought on that?
At some point in Texas, we were below the 9%, and that's really where that was a goal, is to stay below 9% positivity rate, or even as low as 6 or 3%. And to see it as high as it is definitely concerning and suggesting that we don't have as good of a control on the spread of the disease as we'd like as a state or a community.
Is there a positivity rate that we're aiming for? I mean, clearly 0, right? But when do the alarm bells start to ring?
Yeah, what I've read is that public health officials are saying that if you have a positivity rate somewhere maybe below 3% or below 6%, that you have the best chance to get you have a reasonable chance to get a handle on the spread of the disease using traditional public health practices. So that's going to be contact tracing, public health communication, education. And when it gets above that, especially when it gets above 9%, then that's when a lot of different officials around the nation and even the world are saying you need something a little bit more extreme around, shutting down certain sectors of society to stop or slow the spread of the disease.
So we just saw in the news, the county had to close a testing site because of the heat the other day. As we're getting into these summer months when this is going to be, the heat is going to be increasing, what's the contingency plan to keep the testing levels at, normal operating capacity if we're dealing with high temperatures?
Yeah, I'm not aware of what our contingency plans are. That's not a part of the operations I'm familiar with. But I will say that when it comes to any incident response, whether it's COVID-19 or a hurricane, it's always safety first. We want to make sure that public health practitioners are safe, and there's a role. Every health department goes into what's called incident command structure during an event like Harvey, like COVID-19, and there's a position in that incident command structure called the safety officer. And that person's sole responsibility is to make sure that the responders are safe and doing well. And that's the one position that actually has the ability to overrule the incident commander. So if the incident commander says one thing and the safety officer says, nope, we feel like the safety is being compromised with this activity, then the safety officer can trump the incident commander. The incident commander otherwise is the chief executive for all decisions. And with that, we definitely want to make sure our personnel who are out there in that full PPE stay safe, stay hydrated, stay cool.
So we've got the testing, and we're also seeing in the headlines in the news the death rates, and I'm also seeing stuff about the rolling averages. How do these different data points kind of all play together, within the monitoring and the analytics side of public health?
Yeah, it's a great question. So a lot of times you'll see the counts presented as they are. So let's just say today we had 100 cases, and tomorrow it was 500, and the next day it was 250. And so you'll see that number bounce around quite a bit, and it adds a lot of variation that makes it a little bit more difficult to interpret when you're at a peak or when things are changing. And that's where the rolling average comes into play. And what a rolling average is basically saying today's number, the count for today, is the average of the count for the past 7 days. And that's helpful because a lot of times you'll see what we call the weekend effect. So you'll see case counts plummet on a Saturday and Sunday, and then skyrocket on a Monday. And that can be due to many issues. It can be due to just a lag in the data, a lag in testing. If you have a 7-day rolling average, it actually smooths and eliminates that bias such that you get a stable or a more stable number to be able to use for your analysis and interpretation.
So when you have a number on Monday, that's a large number, are you saying that some of those cases, although they're reported on Monday, are attributed to Sunday, and then some are attributed to Saturday and some are attributed to Friday? They're just reported on a Monday in a sort of a large bucket?
They can be. It depends on how they were reporting. Like I was mentioning, there's that epi curve, which is really about when did the person start to have symptoms. So your symptoms show up Monday, through Sunday, and it doesn't really matter. But when it comes to getting tested, or, some people can only get tested on the weekend. Other people can only get tested on the weekday. And so when you see these numbers that shoot up on a Monday, it's important to look at the context and see, is that due to perhaps a real spike, or is it due to the fact that, if the Saturday and Sunday numbers were low, then maybe the Monday numbers are really just a reflection of all three. And you can get around that when you see a rolling average. If you see a 7-day rolling average, you won't have to worry about having to make that calculation or adjustment.
So all this is just so fascinating. And we've talked about COVID before, and I bet a lot of this is just continuing to improve, and we're starting to see, all these different adjustments as we're learning on the fly, if you will. I noticed that the Astros, good old Houston Astros, they apparently do not have the rapid testing then, because I saw that they didn't get their test results. And I believe the headline was because FedEx wasn't delivering that day, or whatever the mode of transit was for the testing. So I guess, from my perspective it sounds like these tests are being sent off to a lab. And if that was the case, that they were being FedExed, are they being sent to like a centralized location? Is it a CDC location? where's the interplay between that, where you get tested, they send the test off to get the results, and are we really seeing? I guess my biggest issue is: are we really seeing that some are more accurate than others?
So with testing, it's originally it was just the CDC who could do the tests. Now we see lots of labs, and they're all doing it with their own processes. They've been FDA approved, so they can provide a clinical diagnosis. And so with the MLB, they sent it to the main MLB lab. I think it's in Utah. That does a lot of also their drug testing, I believe.
So they have their own testing then. They have their own site.
Correct. And so my experience with this is that they probably are going to have a rough start. They're going to work out some of their processes because it's new. Everybody's trying to build the airplane while they're flying it. But eventually, when they add some additional quality assurance and quality control pieces, you'll see the testing be a much smoother process for MLB, to where they'll be able to get that 24 to 48 hour turnaround without any issues.
So you mentioned the CDC being the only lab initially that was doing this test. And, there's a lot of government agencies that are involved here. Could you just sort of break down how this flows, from the data side? The city's reporting numbers, the county's reporting numbers. Texas has the Department of State Health Services. We have the CDC, which I think it ultimately all rolls up to, but you also have FEMA involved in testing, so how does all this fit together?
So this is a fascinating topic in and on its own. There's actually a group out there called the Public Health Network for Law that just a bunch of great people that will answer questions around how do these government agencies work and what's the legal rights. And one big thing that I think that the public's not aware of is public health is, because of the 10th Amendment, a function of the states. So just like police, public health is a police power. So the federal government, the CDC, does not have regulatory authority. They have money. They can definitely say, here's a big grant. Please do the way we want you to do it. They have a lot of scientific expertise where we'll go to the CDC and say, what's the best scientific consensus on guidance? And the CDC will provide that answer. But in the end, it's the states who determine what are the legal requirements and legal powers of public health. So when it comes to testing, what you've seen is that the CDC has kind of, and the federal government as a whole has let the states take the lead. And so you see, while they provide a supporting role, the states and the locals have come together to do what they can to improve testing numbers. And here locally, we partnered with agencies in the medical center and other hospitals and labs nearby, because we know that in the end, we have to take care of our community. And that's only going to come by leveraging all the resources and talent we have in our community to be able to improve testing. The CDC and the feds have done, in my opinion, at least a subpar amount of work in getting testing numbers up.
And what's FEMA's role in all this?
So FEMA provides emergency management support. Since this is a disaster, that they are able to provide logistical support and probably some administrative support. But they're, and I believe, and I may be wrong on this, that they were having a role in the testing sites, the federally supported testing sites, but I'm not entirely sure of their role at the federal level and how it intersects with the local level.
Gotcha.
So it just sounds like something we deal with all the time, a bunch of different silos, a bunch of different sources of data. It sounds like the media could pull and play from different, data points, data sets, so forth and so on. And so, I kind of want to go back to what I've also seen on headlines, which is about issues concerning surprise billing, right? You go and you get a test and then you get a $1,000 bill or something like this. Is there anything, that Eric, that you've seen, which is the most predictable model for controlling your costs?
Not for as it relates to COVID-19. I will say, in terms of surprise billing, I had a bit of a scare with that when my daughter was born. She was 7 weeks premature, and so we rushed my wife to the hospital, and we had no idea what hospitals were covered and what weren't. And so we get to the hospital that we were pretty sure was the right hospital we're supposed to deliver at. And she delivers. She has to sign a bunch of paperwork in the middle of the labor process. And what we find out afterwards is, while her delivery was covered, the NICU was out of network. And so we were at risk of surprise billing. Seemed a little odd to me. It was in the midst of COVID-19, the response, and having a baby that's 7 weeks early. I have now this surprise billing anxiety thrown upon me. Thankfully, though, I was able to work with my insurance through my work and my wife's insurance through her work. And while one of the insurances were out of network, the other was in network. And so our solution was, and thankfully we had the ability to do this, was just throw everybody's insurance onto the baby and somebody will cover that bill and protect us from surprise billing. But in my opinion, that's not a way to do business. New parents don't need that level of stress. And it just seems like something where, when you want to have everybody do the right thing to stay healthy and stay well, in particular with COVID-19, to get tested, to get treated, you don't want them having to decide, well, do I get treated or do I stay home and try to ride it out, because I don't want that big bill to sink the rest of my financial life.
Yeah. I mean, and that's just a big issue for people who may not even have insurance, know?
Yep.
So if you don't have insurance, can you go to the county or the city side? Are they both free?
So for testing, yes, certainly. For treatment, if the Harris County has the Harris Health System, so that's the public hospital system, which is different than the public health department. So that's BenTOB and LBJ, and so those hospitals are funded through taxpayers and supported through our tax dollars to be able to treat and provide assistance to those who don't have insurance. And having said that, if anybody feels like they're suffering through a medical emergency, hospitals are legally prevented. They cannot refuse treatment for somebody who has a life-threatening condition, regardless of your ability to pay. If you feel like you need life-saving treatment, get yourself to a hospital or doctor, or call your primary care physician and seek their guidance.
Yeah, I think that's an important message to send. Is this is a health crisis, and we already got enough anxiety and enough stuff going on in our lives with everything changing. We had Dr. Masood on, and we don't even say the new normal anymore, right?
Yep.
It is how we are. And so, yeah, if it's me, because I'm not giving medical advice, but if it's me, I'm going to get tested if I think I'm going to need to get tested, and I'll sort out the billing issues after the fact. But it'd be good to see leadership do something to make sure that is a predictable process in the future.
Well, the website for the county assessment tool to potentially obtain a code to go get testing is www.readyharris.org. And you can go there. They have the link to the assessment, which you will fill out, and it will direct you to the nearest testing site if you are deemed necessary for a test.
And then for the city...
there's a hotline. There's a COVID hotline, 832-393-4220. is the number that you would call to obtain a code to go to one of the city of Houston's free testing sites.
And we'll be sure to put links down below. And, I can't thank you enough, Eric. I know having a baby, congrats again. We'll be sure to send you a lot of coffee, and you just have a wonderful weekend. And, thank you so much for all this information. So,
Yeah, of course. Always happy to help.
if you're listening, please like us. If you're watching us on YouTube, please subscribe. Hit that subscribe button. Everybody out there, take care of your families, your loved ones. Take care of yourself. This has been another episode of Your Houston. Have a wonderful weekend.
Have a great weekend. All right, I think that went well.
Yeah, I remember that epi curve, and it's so difficult to describe and find what it is. So
The epic curve on just this data, is that dealing with like the rolling averages and the trending and the analysis, or?
it's more, there's two ways of looking at the case count. So you can look at it, how many cases are we reporting today? But today we might have 100 cases that were back from April. And so do you leave those 100 cases on today's value, or do you shuffle them back to April? And that's why we present both, is we want you to know, because what the public hears is, oh, we announced 1,000 cases today, and we have 1,000 because that's what they heard, but really 500 of them were from April. And so when we presented just the epi curve, people were getting confused, like, oh, I thought you said on July 1st you had 1,000 cases, but now I only see 500. It's like, well, yeah, but 500 of those cases were from April, so we shuffled them back into April.
That positivity rate is scary.
Yeah.
Hey,
Yeah,
JT, keep it recording. Like, hit record again, if you can.
I didn't know it was that high.
I mean, so the positivity rate is spiking. We're seeing that. I read that the military is apparently coming in, and there's talks I've been seeing in different Facebook groups, people posting, people saying stuff about, they're getting these refrigerated trucks ready. I mean, where is this trending? It doesn't sound like it's trending in a great direction.
The fact that the governor's talking about shutting down the state, it's bad. That's the last thing he wants to do.
At what point does the positivity rate, do they go, okay, that's it, we're shutting it down? I mean, has that been defined, Eric? Have you seen where they've defined if it hits 25%, that's it, that's the threshold?
Yeah, not to where there's a trigger there's no one trigger that is like, if this, then we shut everything down. So you're looking not just at positivity rate, but you're also looking at things like hospital capacity, at what are maybe some of the contributing factors for the positivity rate. You're looking at special populations like hospitals or nursing homes, and seeing, because that's where we want to keep the disease out of, nursing homes especially, because that has such a high mortality rate. If the positivity numbers go up, and I don't mean spike, I just mean moderately up, but we see that it's mostly 20-somethings, then that's a concern, but it's not quite the same concern if we see it go up and it's mostly 70-somethings. Then it's a much scarier number because of the potential for loss of life. It's the younger you are, the more likely you are to survive COVID-19. And that's why there is no one number or no one metric where it's like, if we hit this metric, we're going to shut everything down. It really is up to our public health leaders or experts to kind of take all that information in and make a call based on their judgment and assessment of the situation.
It does not seem like it's on a good trajectory. And you're going back to that rapid testing, the rapid test, I wonder how many of those, if they're available. Is the rapid test different than the nose test?
It's the same. It's the same swab. It just has to do with how exactly the chemistry on the sample works and the speed at which the chemistry happens. So you see, this was the Abbott test. I don't know if you ever saw the headlines that the rapid Abbott test that came out, I want to say in April. And so they're scaling up production. I don't know their supply chain issues, but you'll see more and more of those point of care tests as supply chain issues get worked out. But they're by and large just as reliable as the 48-hour test. They're certainly, I would trust them if they came back positive or negative from that test.
Does anyone know what the margin of error rate is on these different tests?
I don't.
I think it's pretty low. I asked a lab guy, and he's like, he didn't give me a specific number, but he's like, they're really trustworthy. Especially if it's a positive, then there aren't really that many false positives.
So are y'all tracking like a false positive rate countywide, or?
No, I'm not. I think that would be more a function of the labs to be able to do that than it would be the public health system, because the labs are going to know, and maybe at the state level they could do this. It's just really hard to get lab data in this system.
Well, let's hope that the 10 hospital doesn't need to go back up, and people otherwise follow directions. And from everything that I'm seeing, it just looks like we're going to be back in a stay-at-home situation sooner than later. But yeah, man, with the baby, hey, keep trucking.
We've done maximum social distancing. So like we go to HEB and we do the curbside, and we cook at home or we order takeout. Even with the Uber Eats, they'll drop off the food at the front door. Mm-hmm. Everything's contactless, and I will say it's really encouraging and exciting to see how much of the Houston Harris County community is wearing masks, is being socially distant. I'm sure there are people who aren't, but at least in my circle, I see a lot of people who are abiding by these public health rules and guidelines, I should say. And that's important, because even if you're going to be, a 20 or 30 something who gets sick and recovers, ultimately, if you have to go to the hospital, if you have to use an ICU bed, then you're taking valuable resources from a patient who's maybe older or has comorbidities and needs that ICU bed. And so we want, even as a younger individual, we want to do our part in wearing masks, staying socially distant, and finding creative ways to be socially engaged with people, whether it's through Zoom chats or, FaceTiming friends and family as opposed to going to visit.
Yeah. I mean, maybe even some socially distant testing soon on the horizon, right? Where we actually can get it sent to our home and test and send it off.
There are companies working on that. There was one company out of Austin who tried to push out that product, but then the FDA said, no, you guys are not approved. Please don't do that. But I know that is something that the people are looking into, is that at-home testing.
Well, I'm going to do one more time. I'm going to do the formal outro for Your Houston. I didn't do it this time, but I'm going to do it this time. How many times could I say this time? But thank you for watching Your Houston. Everybody have a wonderful weekend. Bye-bye.